Hello, Vignesh sir.
Yeah, Naresh.
Yeah, hi sir.
Hi, your voice somewhat.
I'm connected through laptop. I don't have headphones.
How
That's
to start Bluetooth? Yeah, Naresh.
sir. I connected through laptop. Hmm.
Okay.
No sir. I connected through laptop.
Am I audible? Naresh, am I audible?
Yes sir.
Okay, done.
Okay.
Farooq sir, Ramkumar this side.
ராம்குமார் நம்ம ஏதாவது ஸ்டார்ட் பண்ணலாமா?
நீங்க ஸ்டார்ட் பண்ணுங்க சார்.
ஒரு ஏதாவது
Sir, Selvamani sir, actually, Farooq sir will do the first presentation. So, Kannan sir and Cecily madam is joining, sir. So, what he can do there?
that's
So,
great.
you, sir, actually, you can start, sir. So, let Farooq sir will be the first presentation. Selvamani sir, you just start.
Share screen.
Selvamani sir, you can give the welcome address and you can invite all.
Yeah,
And
okay.
technical team will go for the recording.
Yes, sir. They are starting recording. Naresh.
Record, sir. When it is ready, just give. Tell me, I will start.
This is
Yes, sir. Recording started, sir.
Yeah. Okay. Good evening,
how to-
everybody.
how-
It is
how to
again a
take the
pleasure.
share screen actually.
Okay, it's again a pleasure to just have this one more webinar on this OCT in acute coronary syndrome and chronic coronary syndrome, part 7. And all these days, we have been having a lot of discussions with many cardiologists and very senior speakers here. And today we have a group of group of doctors here, and we have Chairperson Dr. Kannan here, who has just joined here, and we have Cecily Madam joining shortly, and Dr. Sundar, and we have a presentation from Dr. Farooq here, and Tyagarajan Mahadevan, and Mohammed Aziz. And with this small introduction, we have good panelists also, Dr. Sujay, Nikhil, and Surendran. With this, I think we will start the webinar. Our first presentation will be from Dr. Farooq, and it's over to you, Jawar Farooq. Farooq, you can share your screen now.
Good. It's connected. Yeah, it's joining that. Tyagarajan sir is joining. Farooq sir is joining. Hi, Tyagarajan sir.
Share screen. Ram, share screen.
Please, you share your screen.
Screen is not seen, sir. Now it's okay. Now it's coming. Yeah, it's coming. It's coming.
View share. Why my screen is not there?
Be able to see your screen. Go and open your PPT. Go open your PPT.
Why? Why my not the thing is not getting shared actually?
Farooq ji, you exit, rejoin, and then you press your share screen there. Okay, good evening, Thiago. You are muted. Okay, fine.
Yes, sir. Good evening, sir. How are you?
Oh, good. How are you?
Sir, fine, sir. Fine. Going good.
Okay, good.
So, how's Gavin sir actually? Can he present sir before Farooq sir? We are able to share his screen sir then next week I
Yeah,
can go Farooq sir.
no problem. If okay, I can.
Yeah. I think Kannan sir, I think we'll start with Dr. Tyagarajan's presentation by the time
Yeah,
Farooq
sure,
will be
sure.
ready. Yeah,
Sure.
Thiago, you can go ahead and start your presentation.
Okay, sir. I will share my screen.
Or you
Yeah.
can share it to the central team and we share it from there.
Yeah,
Whatever.
we'll do something.
Yeah.
Getting?
Yeah, I think Farooq sir is sad, it seems.
You have to share screen, but it's not going to the share.
Okay, Farooq ji, just hold on.
No,
Tech
one
people,
second. Go to this share. Share nu pota varnumla.
Vandarchi, we can see that.
I think it's my
This is
screen. It's being
Tyagarajan's
shared.
screen we are seeing. Only one person can share. I think if no Tyagu is sharing, Farooq ji, just wait. Next you can start there.
Okay. That's why I could not able to share actually.
No, he just started
Oh,
sharing now. It's okay.
yeah. Shall I quit then?
Yeah, please. No, please go ahead, Tyagu. You finish your presentation and then.
Okay, sir.
Allah.
Yeah. Very good evening, one and all, and very good evening, Silmani sir and Kannan sir and other Javagar sir and all faculties. And I'll present my case, the left main double bifurcation, how we dealt it. And it was the history of 8 years male with diabetes, hypertension, 8 years on medications, CAD, effort angina, one episode of syncope he had, and blood investigations were unremarkable. ECG was normal, no acute changes, and echo was also normal except for aortic valve sclerosis. And CAG, we have taken a CAG because of back of suspicion of coronary artery disease. It showed left main plus double vessel disease. Left main was having 111 Medina lesion, and LCX OM also was having 111 lesion. It was like LCX and OM territory was supplying large area. This was the angiogram. You can see right side it was good, and you can see that LM to LAD 111 and LCX as well osteal tight stenosis, and OM1 which was supplying a large territory having osteoproximal significant disease. So with this, RC was normal, and with this, the plan is for to take him up for upfront two-stent strategy with LM to LAD LCX with mini crest technique, and DEB for drug-eluting balloon for OM1, which was supplying large area. So we did a pre-dilatation with 2.2512 and then 2.25 21 25 drug coated balloon was used to stent used for this OM1, and then LAD L6 pre-dilatation was done. You can see that after addressing the side branch, we have rewired LCX and from OM1 to LCX, and then LAD LCX routine pre-dilatation with 2.512 at 14 atmosphere, and then positioned LM to LAD 3.5 cross 30 and LCX 2.5 cross 18 positioning, stent positioning, you can see, and we did with mini crest technique here. You can see in the levocaudal view that the stent is opened and then that was removed, and then we are opening the LM to LAD stent. You can see the post-stent deployment, there was good flow, and OM1 is also flowing nicely. And first part was done with 4 cross 8 mm and then followed by L6 rewiring, followed by LAD and LCX post-dilatation. L6 was post-dilated with 2.5 crust 12 at 18 atmosphere, and LAD stent was post-dilated with 3.5 crust 10 atmosphere, the 3.5 crust 10 at 18 atmosphere. And after that, kissing balloon dilatation. You can see that kissing balloon dilatation in the ileocaudal view. And this is the final part with 4x8 at 18 atmosphere. And you can see the OCT imaging. From in the rendered stent view, you can see that here there is a mild edge dissection of the stent in the distal edge below the edge of the stent in the 2D rendered stent view, and you can see otherwise there is a good opposition from distal to proximal, and expansion also was nice. And sorry, I think technical team, can I get your assistance? There is, yeah, you can see now, like. Technical team, anybody?
Sir, I think we are able to see your screen, but it is not moving.
Yeah,
No, you
Can you
just
unshare
click.
share again, sir, possible?
No, click it on the image, OCT image. Just click there.
yes, sir, actually.
Is it? No, it's not playing.
Yeah, actually, that view, I think something has been changed. Technical team, anybody there? Multi-speaker.
Yes, sir. Yes, sir.
Yeah, can you change it to this slide view? This I can see, but it's not moving.
Sir, can you unshare and again one more time share, please, if possible?
Okay. It was going good.
Is it not going to the next slide? You're unable
Yes,
to
sir.
move.
It's not going to the next slide
It is
because
stuck there.
it's stuck there. Can you see anything is moving, sir? No.
Nothing is moving, but we are just seeing that slide,
Yeah.
final part and
Now?
OCT. It is not moving. It's stuck there.
Okay. I'll do stop share and reshare, sir. No other option, I think. Anybody?
Can you share once again, sir?
Yeah, I'll share again. Yeah, it's moving now, no?
Now it is moving. Yeah.
Yeah, you can see that. Yeah, you can see that but it's not moving, sir.
No, it is moving. It is moving.
Yeah,
Yeah,
fine.
okay.
Yeah, good. Yeah, you can see that the OCT is moving. Yeah, now you can see in the left main also the approximation is good, and this is the OCT image. So with the help of this OCT image, what we have come to know is like, the proximal LM MSA was good, 13.5 odd, and distal LM MSA was also good. Ostial LAD, it was around 7.67, and distal LAD stent was good MSA, but we did notice the dissection, and this is the 3D bifurcation mode, which shows that there are no stents across the L6 ostium. So we are happy with that after the kissing balloon dilatation. And so OCT showed the distal edge stent dissection. So again of a length of 6 mm. So with this, we have to again to put one more stent to cover the dissection area. And then after this is the final angiogram, you can see in the yellow caudal and PA cranial and PA caudal projections. And LM to LAD was nicely flowing, and OM also is good. And OM1, which we have did a drug coated balloon, is also flowing nicely. So the take-home message here is drug-coated balloon is an option in patients with double bifurcation for side branch like this because it was closely origin from the LM and LCX ostium and left main bifurcation. Imaging helps in optimal results. Nowadays, it's a class 1A indication. Without imaging, the distal edge dissection would have been missed. It might lead to adverse outcomes. Similarly, it's not only the distal edge dissection, LM approximation and LCX ostial strut-free osteoproximal area should be there. Otherwise, there will be again restenosis chance will be more. The adverse outcomes will be more. Though DK has shown better outcomes in studies, individualization of techniques is most important. In this case, Minicus techniques was opted owing to patient's age and simplicity, and we are comfortable with that because he was 8 years old octogenarian. So we don't want to prolong more the time. So I did have gone with the mini crest technique. Thank you.
So, nice case, Thiagu. Nowadays, it has become routine that we start treating a lot of left veins, and
Yes, sir.
especially in a very elderly patient. And what obviously different I saw in your cases, you have not done a pre-OCT. Why was it? Any reason for that?
Yes, sir. Pre-OCT, I have not done because after doing that OM1, this thing, pre-dilatation, he was having some sort of chest pain and all those things. So I did not go because I wanted to finish the procedure earlier and I didn't do that. After that
Oh.
OM1, he was having some slow flow in that OM1. He was moving with pain and all. So I thought, okay, better just finish this and then we'll take a final OCT run and then we'll optimize because that's the main reason. That was the reason.
Okay, probably this patient was unstable. That is why you did not do. But
Yes, sir.
otherwise,
Yes.
if you do a pre-OCT, you will get a very good idea. The stent where you landed initially in the LAD,
Yes, sir.
probably if you had done a pre-OCT, you would have taken a still longer stent.
Yes, sir,
Actually,
definitely.
you landed in a diseased area.
Diseased. Yes,
Probably
sir.
that is why you had this dissection there. And
Yes, sir.
probably, rightly you did, you covered the other lesion also there below that.
Yes, sir. Yes, sir. Actually, that our plan was like just dilate all and take an OCT run, and then based on that, choose the size of the stent and then come out. And if after OM1 deb and he was having some discomfort and moving here and there, so I did not do all those things. And then I want to secure LM to LAD, LCX flow, and then do this.
Okay. Do you do generally all left mains with minicrus or some other techniques you
No, sir.
used?
Depends on the anatomy and the patient's stable or not. We do decay crest more than this mini crest, and OCT also we use. Without that, we don't. Without OCT and left main cases, mostly we go with IVS run also than OCT.
Okay. Very good case, Thiagu.
Yes, sir.
Probably
Thank
that
you,
was
sir.
one
Thank you.
part where the pre-OCT, but more generally, the recommendation is if this case is different for any other procedure, pre-OCT gives more information than
Yes,
a
sir.
post-OCT. And probably it is acceptable in an unstable patient. Many times we may not be in a position to do that. Good presentation.
Yes, sir. Thank you, sir. Thanks.
Yes, Thiagu. Any other comments, sir? Kannan sir or Farooq, you want to add something for the case here for the discussion?
No. Yes, presented very well. Actually, you could able to hear me.
Yes, sir. Yes, sir.
We can hear you. We can hear you.
Excellent presentation. Actually, yes, demonstrated the latest aspect of using the combination hybrid technique to do double bifurcation. Excellent case.
And I think the imaging, without imaging, I think the distal dissection would have definitely been missed. So
Yes,
I
sir.
think
Definitely, sir.
it was not very well seen on the angio, that is for sure. So very good. That was a good takeaway from this case. Yeah.
All findings of the
Farooq, we can see your slide.
I can go ahead with my presentation.
Yeah, please go ahead, Farooq.
Thank you very much for opportunity. Nice to see Salvamani, Kannan sir. You know this, there is an increased recognition of OCT capability and they recognize central role in guidance of coronary bifurcation lesion, especially the left main PCI. The angiogram will continue to be a primary guidance modality, but imaging will change the outcome with large amount of evidence which has come back now at present actually. So it's probably the continuous training of intracoronary imaging is needed as the Madurai team is doing extensively and coming out, and we are also seeing these results actually. It is the best approach for intracoronary imaging is best approach for achieving an optimal result of bifurcation stenting. And our important thing is getting a final configuration which is achieved in a stented area. And success depends on that with specific distinct steps and added improvement to whatever technique has been done from last 1 decade. Not all possible technical imperfection could be identified, but imaging definitely will identify the problems like bottleneck deformity, the malapposition, the underexpansion, and edge dissection before going for next step actually. The intracoronary imaging guidance would be regarded as a gold standard. Angiographic guidance maintain a central role in bifurcation practice. This is one trial I am showing, this October trial. We given a conclusion in a patient with complex bifurcation, OCT is guided PCI is associated with better outcome after 2 years than angiographic guided PCI, recommending as a class 1 indication for all bifurcation lesion, especially left main bifurcation. This is an illustration which came for lung bifurcation. This is a beautiful illustration for percutaneous revascularization, whether to select 1 stent or 2 stent. Look at this baseline complexity. Assessment can be done by angiography. If it is Medina 1110, 11101, that means significant side branch involvement, or side branch access is challenging, you can go with upfront 2 stent, or the imaging shows severe side branch lesion of more than 10 mm or block morphology, calcium more than 60%, upfront 2 stent strategy. But otherwise, you can select stepwise the provisional stenting. After crossover, angiogram says the less than TB3 or severe the side branch is pinching more than 90%, or intravascular imaging show a medial dissection, MLA less than 4 mm, or physiology is FFR less than 0.8 or 0.89, you can escalate to 2 stent. Otherwise, you can optimize it. It's a wonderful algorithm. The definition criteria has changed. The complexity can be defined with an evidence with the definition criteria where side branch lesion and diameter for left main is more than 10 mm and 70%, non-left main is more than 10 mm and 90%. Minor criteria being mild calcification, multiple lesion, bifurcation angle less than 45 or more than 70, or the reference vessel diameter of main vessel is less than 2.5, lesion length is more than 25. These are all clearly defined actually. The history of CRESS, the technique has undergone, all this technique has undergone an evaluation. Look at this, CRESS has started in 2003 as a 3-layer, just a recross failure of 25%. They sent for a surgery. It is modified into an original decompression into the 2005 3-layer stent, then become a mini crest. But the patterns for the side branch optimization is changed with the optimization of stent layer by 2 stent, and imaging definitely has changed the whole outcome actually. This is one of my cases which has been done something around one decade back, acute coronary syndrome. We have angiographic showing 001 severe osteal LCX. And imaging has helped us to redefine the classification. You can look at this, the beautiful imaging which was done 10 years back actually at Meenakshi Mission Hospital. You can see this landing area ALL, you can identify 3.4 or 4.4 accurately sized and approximately 4.1. And we had the angiographically unseen lesion which is seen in the main important, the LAD osteum showing a fibrofatty plaque with flaps and also thrombus. If you would have selected 1 stent, you would have definitely uploaded their artery. The second branch also is showing a complex multiple lesions. Actually, the complexity you can identify very easily with calcification, which is mild to moderate, and also at the point of the lesion, there was a fibrofatty ACS lesion. It was a lipidic lesion with a flap with a layered thrombus at the point of the osteum actually. Look at this actually, tight lesion. So it has definitely shown the morphology. It is OCT wise, it is 111 morphology with mild distal development involvement, upfront 2 stent strategy. The entirely OCT guided now at present actually. We implanted the main branch stent with the protrusion of the classical description of a decay crest, 3 stent into the left branch. Crest balloon has been moved into when you are applying the stent near the proximal stent strut, actually, first crest. And after the first crest, we did this OCT and looked at the LAD lesion, again redefined the LAD lesion 2 times. We defined, actually. We confirmed the proximal and distal landing in the LAD and confirmed the proximal cross. This is very important OCT. Definitely, you confirm the proximal cross. First case followed by a DES 3.5 stent and check angio.
Right-handed.
OCT pullback to look at the expansion, the MLD max algorithm, expansion, apposition, and medial dissection, and further optimization of side branch after the OCT. And we confirmed the second cross, middle cross, and this can be only done with OCT and final case and the final part. And that was the final result. We could able to beautifully image without any metal ostium and proper exploitation, the optimization of the proximal main and also distal main, and come out with this result. And nearly after a decade, I have seen this actually. This patient has come back to me. I did a CT angio showing a wonderful stent actually. She's doing very well after 10 years. She would not have done, I think, better than this with even with the CABG. It is only the imaging which has helped. Look at this actually, the stent which has been done 1 week, 2 weeks back, I had done this CT angio showing a very good stent. She agreed for the angio and shown an excellent result even after 10 years actually. This is another case in which we had a dilemma. This patient came with ACI, the culprit lesion was stented, and this had a complex, the non-left main bifurcation. And our assessment was little more, the angle was little uptake actually. We thought we'd come out with T-stenting, and we pre-dilated, did a OCT. OCT showed the tight lesion at the level of bifurcation, and the lesion length is fulfilling the definition criteria of more than 10 mm. The side branch lesion length. So this was a ACS lesion actually. So we did the pre-dilatation and stented this, and with thinking that we will come out with the tap, and ultimately when you cross after the proximal stent, the side branch optimization, we could not able to pass the 2 mm balloon. That means the small amount of stent was protruding, and you have to step crest, we have to take a 1 mm balloon and upgrade it to 2 mm, and ultimately we stented with the nano crest technique with optimization of pot and also the final kissing, and we did a final OCT. Final OCT we did with two pullback with one catheter in actually. We wired side branch, we did a side branch OCT, and we confirmed this optimization here. And then we pulled the OCT catheter, parked in into the guide actually, then rewired the main actually, and ultimately we came out with a beautiful result actually. This patient is extremely done well. I look at these 2 stents stitched together, and without very good optimization of the proximal main, and you can see the sizing actually. This is all done with the pot and side branch optimization. That was the final result. Patient is doing extremely well. And ultimately, this patient had an equal size main branch, side branch, and reverse tip tap landed up with a nano crest, and OCT was helpful guidance of optimization. This was another case in which a 61-year-old had a VTVF and came with cardiac arrest, and they had this sort of a lesion, and we could not able to morphologically define this ACS lesion actually. We did a OCT pullback shown a lipidic plot, the high lipid-rich plot, and with severe stenosis at the ostium actually with a white thrombus, ACS lesion. And lipidic block, we avoided the pre-dilatation, directly stented actually. We did a post balloon, and after that we did a post OCT actually. Side branch was not involved, pinched, and came out with a wonderful result. Post OCT showed a very good ostium, side branch ostium, LCS ostium, and that was the final result actually. So attempting to simplify and standardize approaches is very important. Limiting number of stent was the aim for left main, the EBC main trial. In EBC main trial, only 20% needed a second stent actually. The planned 2 stent strategy was considered when there is atherosclerotic involvement of side branch extensively, and decay crest they preferred, promoted very well actually. The adequate expansion of proximal edge is very, very important. That can be only achieved with pot, ideal pot. That is very, very important. That has changed the outcome of all bifurcation lesion actually. And for all major bifurcations, the side branch optimization pot has to be done with correct technique actually. So the by-arc endpoint classification is shown. The procedural success depends on proper placement and optimization of bifurcation segment, and that produced the absence of in-hospital major event. This one of the patient with octogenarian came with sort of a lesion, simple lesion there. They were difficult to access. We had lost the femoral access. We went ahead with the radial access, multiple loops, and this patient we wired both actually, and pre-dilated the lesion. Difficult to even take a balloon there actually. Stented with 3.38, optimized with the pot, entirely angio-guided. We could not able to take an imaging catheter, and that was the final outcome actually. So this key principle of bifurcation promoted by European bifurcation therapies keep the procedure simple and safe. Respect the original bifurcation anatomy and physiology, and aim just to reproduce it. Limit the number of stent and use kissing balloon optimally, use pot optimally, implant second stent only if needed with T-tap or plot. Consider significant side branch involvement post actually after implementing provisional. That is stepwise provisional standing strategy. If there is impaired TIMI flow or side branch or significant stenosis of more than 78% or extensive dissection, you can decide about second stent. Remember that the step down in the reference is very, very important. The sizing of first stent should be 1:1 for distal main reference vessel, and choose the 10mm platform which accommodate the expansion proximally. That is very, very important. Use the pot balloon with size of 1:1 proximal main vessel reference diameter. Be aware of geographical risk during the pot. Avoid a bottleneck configuration, and limit the metal overlap. That is very, very important. Long segment of one metal overlap always produce a lot of stent failure, and multiple layer is always dangerous. Reduce the stent overlap by reducing the protrusion in the crest or a plot actually into the main branch. Suboptimal stent expansion, all segment has to be avoided. That will produce a stent failure. And it should be accurate. Stent expansion should be accurate. It should be estimated by intracoronary imaging. And any major under expansion should be immediately corrected before going for a second step proximally. Optimal lesion preparation will before stent implantation is very, very important, especially managing the calcium in each segment is very, very important. You have to over-dilate by 5:10 to compensate for recoil, to aim for TIMI3 flow, minimize the residual stenosis less than 10%. Major mall opposition is associated with major cardiac event. Stent opposition can be accurately estimated by OCT, but major mall opposition will be recognized by meticulous angiograph. Sometimes we will do a stent boost the technique actually, and use stent enhancement technique there possibly. Do a multiple orthogonal, the projections, orthogonal assessment when you do an angiographic assessment, and do a puff, that is contrast puffing, to find out a gap in between the stent and the vessel layer. And angiogram always encounter the limitation actually, but the pre-PC angiogram require careful consideration to identify optimal angulation for visualizing a critical aspect like plaque distribution, vessel relevances, and the subsequent post-PC assessment actually. No single best projection is capable through evaluating the entire bifurcation. You do a multiple projection to get a good anatomical the understanding of a bifurcation. And stenosis severity and plaque distribution, visual assessment of the coronary bifurcation limited by inter-observer variability. That is very, very important. Get a second opinion, third opinion, cath lab. You may give a better opinion. Sometimes you have a tendency to overestimate side branch. QCS always traditionally can overestimate actually, can produce dissection actually. And IVS OCT on an average can have a larger than those derived from QC. OCT is accurate, providing high accuracy, especially EEL is very, very important for selecting a stent size actually. The diameter of balloon and stent has to be identified. When you use a semi-compliant balloon, you get a nominal pressure with can produce a maximal expansion, but when you use a non-compliant balloon, you need to have higher pressure. You have to dilate with higher pressure to get same expansion. This is what wedge test. The number of balloon inflation is very, very important. Sometimes you may get the nominal expansion, the maximum expansion with third or fourth dilatation. You look at this, the nominal pressure achieved. Left main is a different anatomy. You can have overstage propium, continuous block, continuing block. You can have a large disparity, diameter, the vessel disparity, and we have a wide angle. But this anatomy has to be identified, and proper technique has been seen actually. The part, this is what happened actually. Part will facilitate side branch wiring. The scaffolding of side branch is very, very important. That's what is important for the modification, which has resulted in a success in most of the two systems. So routine casing for a single stent left main PCI, FAR is for younger age, severe side branch disease, downstream side branch disease, Elective stenting, you need a routine kissing. Old age, mild side branch disease, no downstream side branch disease, and acute stenting, you need not do the routine kissing of this actually. So this is expansion capacity. I told you what to identify the how much maximum expansion we'll get from synergy, onyx, Zynes. This can expand. This Zynes can expand from 3.5 and can go up to maximum can go up to 5 or 6 actually. This is very, very important when you have a single stent which is implanted. There is a disparity between two reference diameters. This has to be understood before implanting the stent actually. If you look at this actually, one stent which is you can make the 3.5 stent to 3.3, 4.3. Say the same four stent also can make it as a 3.3, 4.3. So how much dilatation you do, how post optimization you do, that will decide the final MSA actually. So this is one of the suboptimal stent implantation by imaging. Look at this bottleneck deformity. This has to be very early identified and corrected. And the imaging will give an accurate assessment of that bifurcation point actually. Side branching wire check can be accurately done only with eye imaging. Still you can use this angiographic fluoro, but imaging will give an accurate the course of a side branch wire. That is the way to confirm. OCT represents gold standard imaging modality to assess the rewiring site bifurcation in all intervention actually. OCT guided distal rewire, the distal rewiring has been proven to be associated with more favorable stent healing than the angio guided actually. It is a very, very important point you have to remember. Look at this actually. I have shown it in my case also. The rewiring can be assessed accurately by this imaging actually. So the intracorneal imaging is increasingly considered to provide gold standard guidance for bifurcation with evidence demonstrating superior result to angiography. And however, the education and access to technology remain a major barrier to intracorneal imaging adaptation. You need a large volume of training for all centers to get trained into this technique actually. Pre-PC imaging is very, very important actually. Sometimes you have to use angiogram to, because the CT angiogram to assess the calcium. The systematic application of technical steps suggests for a given selected technique, and the intra-procedural, post-procedural PCG, the use of stent enhancement in angiogram is very, very useful. There is low threshold for bailout use of intracorneal imaging. I want to show some of the results, Nordic Cactus trial, British bifurcation trial, which are all shown the positive result for a provisional stent strategy. And this is one of the meta-analysis shown the double stent associated with the increases of MI compared to single stent actually. The Nordic bifurcation study 5-year follow-up has shown that result in favor of the stepwise provisional single stent strategy actually. In all lesions, the same result actually. This was the Nordic bifurcation, the complex lesion showing the favorable result for drug-eluting stent, double stent strategy. This was a meta-analysis showing the favorable result for single stent and the double stent strategy actually. And this definition 2 trial, they use this definition 2 criteria, define the complex lesion, and when you define the complex lesion, for a complex lesion, they do 2 stent strategy better than single stent strategy. And DK-CREST-5 consistently is shown that actually a better result for 2 stent. DK-CREST trial is shown for a DK-CREST better than the provisional stenting. You all know it actually. And the European bifurcation, the left-main trial supported the stepwise provisional stent strategy. The problem here is EBC main, the selected simple lesion. You can look at the syntax was 23 compared to DK-CREST syntax was 31. They used the operator experience was 150 compared to DK-CREST more than 300 PC operator experience was more. And upfront truth stent strategy was selected in all cases of DK-CREST compared to less cases for 2 stent strategy actually. This is because of that they had a difference with EBC. They selected less complex lesion with less experienced operator that produced a more favorable result for provisional stenting strategy. That was the EBC main result. And they concluded that stepwise provisional strategies should remain a default for distal left main bifurcation intervention. Ultimately, in 2025, what take-home messages? Non-randomized data has demonstrated the worst outcome with 2 stent strategy in left main PCA. In DK-CREST-5 and definition 2 trial, which enrolled the patient with more extensive side branch disease, DK-CREST yielded a lower rate of TLR than the provisional stenting at short-term, mid-term follow-up. And in our experience also, we have seen this actually very well. EBC main trial provided a support for the safety of a stepwise proximal stenting strategy approach for treating the true left main, distal left main bifurcation stenosis with less complex bifurcation feature. But OCT guided bifurcation PCA improves short-term mid outcome with October trial has come out with a strong evidence, making it as a class 1 indication for doing all bifurcation lesion. Thank you very much for giving me.
Farooqji, superb coverage of bifurcation stenting. You have spoken about like a PG class teaching the intervention cardiologist, covered everything. Very nice. Nice cases, nice follow-up, and extensive literature you have covered there. Thiagu, you want to add something? Dr. Kannan, you want to say something? Others, Mohammad Aziz or somebody?
Wonderful selection of cases, Farooq. You done a wonderful job. And see, the take-home message is that the threshold to use a second stent should be kept at the level but dictated by the OCT would be the best option when treating these cases. That is the take-home message. And unless you have a compelling indication, single stent strategy definitely scores. But then there are some types of left main provisionally we plan for a 2-stent strategy. So other than that, I think it's a very wonderful series of cases. Thank you for the presentation.
Thank you very much.
Yes, sir. Javagar sir, it was all left main and non-left main cases were superbly dealt with. All your with the help of imaging as well and non-imaging era as well. How you have shown that one case, the recent CT is showing that still it's doing good, means that we are more giving good outcome than CABG. That's the message that what you have given now. So better to go with syntax less. Definitely, we need not hesitate to go with left main bifurcation with the help of imaging. Is the take home message what you have given. Thank you, sir. It was all nice cases.
Definitely, the imaging has changed the whole outcome. Actually, we could not have done even that case which is coming here. She ran away with as though she has undergone a surgery. She did a nice lifetime modification. They were become thin,
Yes.
reduced the cholesterol properly, kept the glycemic status very well under control, reduced her stress. She was a professor actually. She never used to come.
Okay.
Once in a year she used to come actually. She's doing extremely well. But that case was differently done. Even so long ago, it was done differently, done with one pure OCT. We have done around 5 pullback. The OCT
pullbacks.
5 pullback, looking at rewire. And there is
Okay,
the optimization was done with each meticulously with each steps, and the part was used correctly.
Yeah,
Optimization.
yeah, you have shown all proximal cross, mid cross, and
Yeah,
how it has helped them.
We did with the entire OCT guidance. That's what is. There was a very big teamwork from Meenakshi Mission.
It was nice. And
So-
sir, how like 001 lesion, LCX osteal lesion, like always we are worried about the recoiling at LCX ostium, and in that case, how to go about 001 just for
No, in that I shown that image. You know, it was not a zero.
yes.
001 was angiographically. That was misguided with. It had a
No. Yeah. Okay.
LAD had a ACS lesion. LAD had a lipidic plaque. LAD had the OCT waves. LAD showed the stenosis even at the ostium of LAD.
Yes, sir. Actually, not in your case. And my question is like from the experts, like
this case illustrates that whenever there is a left main bifurcation, even if you are decided to do single stent, especially when you want to avoid a stenting of the vessels like LAD, you cannot take this decision actually without imaging. Imaging has to do. That is called ultimately called fitness for surgery. Imaging has to do. Imaging clearance has to be done. It will be done meticulously. That's what I feel. That case itself demonstrates. No, you would have done an osteal landing of LCX. You would have done the optimization with single stent. That's all would have definitely resulted in catastrophic result. She is not also a candidate for CABG because there is angiographically there is no significant critical lesion LAD. Only decided the CABG angiographically. That was the dilemma with that case, which was done only with OCTs guidance. That was a beautiful case to demonstrate.
Yes, sir. Yes.
The master is sitting there actually. Master who guided is
sorry, I got disturbed by the phone, but anyhow, But Thiago, what I could hear is you were talking about isolated LCX
L6
lesion.
osteal lesion. Yes, sir.
lesion. So, see, the incidence of isolated LCX osteum lesion is very less, number one.
Yes.
So, per year, probably in my center, I do probably 1 or 2 cases of isolated left circumflex osteal disease. That is 001 lesion. So it can be treated in many ways, but off late recently what I'm doing is most of the time we use a cutting balloon, get a good lumen expansion, put a drug-eluting balloon and come. This is the current approach, and I have some 4-5 cases follow-up, which they are doing extremely well. So out of the 4-5, 2-3 are only treadmill negative, and we have done 2 check angios, which is normal. Before that, what I used to do is we used to put a stent from the left main into the circumflex and just do a kiss into the LAD and come back. So this is probably we did some 3-4 cases. In that, we had some problem with the LAD after some time. So this has happened. But off late, if it is really isolated osteal LCX lesion, we treat with drug-eluting balloon. And one case recently I did just osteal landing of the circumflex stent. That can be, it all depends on the case. If it is a significant recoil, many times, although we theoretically talk that you dilate, do and all, practically, when you dilate it with a balloon, it will recoil. So lumen will not be holding. In such case, we have done just osteal stenting also we have done. So this depends on the case and the outcome when you are proceeding with the case there. You will have to keep all options open. But mostly 90% of the time you can treat it with a drug-eluting balloon. It's a possibility. But sometimes if there is a dissection, we had one case where we dilated the osteal circumflex, but dissection extended into the left main. So we had to put a stent from left main into the circumflex. So anything can happen when you're doing the procedure.
Yes, sir. Yes, sir. Yes, sir. As you said, I do have 3 cases. It was all done with imaging guided isolated LCX lesion over 6 years, and 2 are doing good. One has had a RICA, ISR, and then I did a drug balloon. So far, he's not having any problem. All I did LCX to LM to LCX crossover like semiculate and left the LAD because LAD was good. Or few instances, the 2 cases, left L6 was the dominant circumflex. Maybe it depends, as you said, it all depends on the individual cases and how to deal. Yes. Thank you, sir. Thank you for your input.
So I think we will go to the next speaker. And I think next is Masuda, who is there online. Mohammed Aziz.
Yes, sir. Am I audible, sir?
Yeah, you are audible, but we can't see you.
Sir, good evening, sir. I'll just switch on my video.
Yeah.
I'm
Yes,
visible
Aziz.
here.
I think you can start sharing your screen.
Yes, sir. Sir, is my screen visible?
Yeah, we can see that.
Yes. So good evening to one and all present here, sir, to all the my respected mentors, teachers here who are sitting in the as a panelist, chairpersons, and moderators. So and also I would like to on the outskirt I would like to thank About Vascular for giving me this opportunity. So this is actually a case which is which could be done simple like without imaging, but I want to emphasize the importance of the imaging in this case. As she is a 68-year-old lady. We presented with some epigastric discomfort for 1 week on and off, diabetic hypertensive, and a CKD. Creatinine is around 1.8, and ECG and echo were not significant, but the enzymes were positive. So we proceeded with the angiogram. The angiogram of the left side was a severely tortuous coronaries there. Which made us alarm that the right side will also be bad. And there was a lesion in the right RCA in the mid segment, angiographically significant. And it was kind of a more of a shepherd crook RCA with multiple tortuosity. You could see some 90 degrees, 180-degree tortuosity there. So I planned, so pre-planning with this angiogram was like to go ahead with the PCI to RCA with imaging guidance. And since I knew that once I wire it, all the there would be much of concertina and other things. So I wanted to make sure which in angiographically itself, which was angiographically looking a better zone for landing proximally and distally to the vessel there. So in this view, I could see there was some at the level of, can you see my mouse? Just have a mark. So I could see that this region looks a little bit more of a block-free zone, and distally, I could see some block here just after the lesion. There's a zone here which is visualizing as a block-free zone, and some block here, and I could not see here anything because there was more of tortuosity there. So I went ahead with the imaging. After wiring, you could see that totally the coronary became straight there, and I did a saline OCT. Till now, I did not use any contrast. Only the angiogram was done with contrast. The PCI was planned 2 days later. After wiring, then OCT was done. This was the OCT image. So I want to discuss about this image right now. Sorry. So, wait, I'll just show it in this image. Yeah. So this was, I just wanted to correlate the image with the angiogram, OCT image with the angiogram. Distally in the A zone was the distal part of the culprit lesion there. You could see here, there was so much of macrophages and it was a vulnerable block there. We could see so much of shadowing of the macrophages, lipid-rich region there. After that, the MLA, which was the MLA there, MLA was about 1.09. And here also you could see a huge lipid core, and there is a high backscatter with low penetration there. And on the right side, the seat is a lipid pool could be seen in 3 quadrants, and that correspond to this segment C. And angiographically looking good segment, which I told I could land the stent there in this RV branch region, also was having a lipid-rich block from the 12 o'clock to 6 o'clock position. So I thought just proximal to that region, I had a landing zone where we could see more of a fibrous block there and a good lumen area there, and which corresponds to this C. And the total length was about 18 mm. Distal to this A, there was a block there, but that block was a more of a fibrous block, and the MLA, I mean, the lumen area was good. So I decided not to cover that also. And so the total length of the lesion was 18 mm. I took a 3 cross 18 mm stent. And went ahead. Before that, I just wanted to pre-dilate because there was so much tortuosity, and I didn't know whether the stent could track that region. So just took a small 2 mm balloon. I didn't want more nasty dissections there. So 2 cross 8 mm was taken there for pre-dilatation, and I just took a angiographic shot to make sure that there was no major dissections there. And the next was the stenting, and this was the second shot which I took, and just to position the stent, and I stented that region. After that, I tried so much time, so much maneuvers to recross with that OCT. You could see that I was struggling with that because so much of tortuosity, the wire bias was there, and the studs did not allow me to cross the OCT. So I deferred recrossing the OCT there. But I took an angiogram after that. It was angiographically, it was good. So I had to call it off. The total amount of contrast used was only 12 ml there overall. And with this, I want to conclude that OCT, and here in my case, the OCT was useful for identifying the vulnerable blocks, the length of the stent, the dimension, as well as where I want to exactly land it. Distally, I just chose I just wanted to exactly show you the just a minute, yeah. So I want to show you this was the block which also I was telling more of fibrous here, and I could see a concertina here. Here you could see some tight kind of stenosis here, but it is a concertina effect there. And just coming proximally, this was my landing zone. It was a clean zone there. And then I came more proximal. Then you could see more of this is the MLA there. This is a lipid rich zone, vulnerable block there. This is all taken before pre-dilatation. And this is the lipid rich pool which we saw in the next images. And this was where the angiographically it was seeming okay, but and here you could see so much of lipid pool from 12 to 6 o'clock position. And after this, there was a small RV branch which I was talking about. Just prior to that, I could see a good landing zone here, so I decided to land here. Distally, I took another RV small branch there. I'll show you here. You could see a branch. Yeah. So here I could see one branch coming, and just proximal to that, I wanted to land that. So this is how I decided to stent the RCA, take the length of the stent as well as I definitely OCT helped me, but if I would have been more satisfied when if I had done a post OCT, but I didn't want to spoil the good result by just pushing the OCT and deform the stent. So yeah, so this were the things I noted that OCT helped me. OCT helps to define the lipid-free landing zone for stent safe stent placement, optimum stent expansion and opposition. And saline OCT in particularly, especially useful in CKD patients. Saline OCT, I found it very much useful, especially for RCA. For the left, you need more of saline, better with the power injector rather than hand injection. Power injector for the left LAD and LCS because it carries a larger volume of saline there. So it avoids contrast, obviously contrast-induced nephropathy with maintaining the excellent image quality, which we, especially lipid-rich pools, is quite difficult to identify in other imaging modality like IVUS. So OCT helped me through this. I'm happy to take any questions from you, sir.
Okay. Very nice
Thank
presentation, Aziz.
Thank you,
And
sir.
this is now saline OCT is a very important thing. And as you rightly said, for right coronary artery, it is very, very clear. And unless it's a very ectatic, very big RCA, you may not get a good clearance. Otherwise, in most of the cases, RCA, you will get very good clearance with saline itself. And the problem comes with the left only. For left, if it is a very big left main, if your guide is not in good position, and probably like if it's a very big LAD, then the clearance is a problem with the left system. Otherwise, if it is a small vessel, if it is diffused and if the circ is not huge, if you keep the guide in the ostium of the LAD, probably you'll get a good clearance with saline. And we can use a guide extension catheter also.
Yes.
But coming to the power injector with saline, it is good that you have an experience with power injector with saline for the left system. How useful is it? Because what I have seen is when you give a saline there, the power injector, it gets pushed away very fast. And you may not get a full back. So probably we can, I would like to hear from you how you do that power injector with saline for the left system.
Sir, actually, I have not tried it. Sir, wherever I'm working, this is a single cardiologist center. So I have tried only with hand injection for the left side. I got some good quality image, but there was some blood swells in the LAD. I did it with hand injection, saline OCT for a left system. In my next presentation, probably I would present that, but the LAD image, I could not get it properly. But as you said, guide extension is a very good option. Especially if I'm going to planning for a stenting from left main to LAD or kind of thing, or a bifurcation thing, because whenever we are going to use, if unless it is a very ectatic, a huge vessel, we could use a guide extension without injuring the proximal part of the vessel. Otherwise, I think the guide extension in a small vessels, I think even hand injection will be good. With especially as you said, sir, we have to engage the guide properly without, I mean, like very good hand injection with a normal, I mean, a small size left system could be very much give us a good image quality. But as I told you, what I heard from my other mentors were like power injector could be better for the left system. My experience is not much, sir, in that. Anyone else could share your opinions, sir,
No,
regarding power
the
injector?
experience with power injector with saline, we have tried few cases, but not very happy. But anyhow, if somebody is doing it in a good way, I would like to learn from him
Sir,
also.
sir, actually,
So,
30, 70, it is working, sir. Even 30% contrast, 70% saline. The
no,
same
we are
50,
talking
50
about
are
pure
working.
saline.
But
Pure
100%
saline.
saline, we are not able to get it.
That is what I'm saying. See, that 50-50 is the standard that we use routinely. So in our practice, we don't give 100% contrast. It is 50-50 is always there. That is not a problem at all. But the problem comes when it is 100% saline with a power injector, it's a problem. But anyhow,
Yeah.
a nice
Yes,
presentation
sir.
and your demonstration of concertina and OCT was excellent because it's very difficult to pick up concertina and OCT. Many times you will feel that's a lesion, and but most of the time you'll have to correlate with the angiogram also, especially for concertina. So in a vessel like this, which is very crooked, and then you put a wire, it becomes straight. When you do an OCT, there will be infolding like picture, which you clearly demonstrated. That's a very important point in, especially in a vessel like that, on OCT. Because in the beginning, you might feel that that's also a lesion, and you can keep on extending your stent length, thinking that that's a lesion. But picking up concertina is very important. It will be looking like probably there is a narrowing, but there will be infolding at the vessel. So that was a very good demonstration. Very nice, Aziz.
Thank you, sir. Thank you.
Yeah. Any other comments, Tyagu, Kannan sir?
Yeah, yes, sir. It was good, Aziz sir. And actually, the one more thing is you would have used co-registration. I don't know whether you had that at that point of time or not. If you have used the co-registration for that 2-3 contrast injection chart you have used, that could be avoided. And it all depends on that. And to Selvamani sir, one question: Can we use dextran instead of this saline? Have you ever
See,
tried, and how much it's helpful?
No, actually, see, there are three things that you can use instead of contrast. One is
Yes,
the
sir.
saline, next is starch. We have
Start.
starch, and then we have this dextran. The problem with dextran is dextran also is equally kidney toxic. Many times they develop nephropathy at the end of 1 year when you use huge volumes of dextran. So that is why
Okay.
it did not pick up. But when the clearance, when you compare, dextran is better than plain saline, and starch is also better than plain saline. So we have used a few cases with starch also, where you get better clearance than with plain saline because the osmolarity of these fluids are different. That is, I forgot the value of this osmolarity. Compared to saline,
Yes, sir. It's
osmolarity
thicker than the saline.
it is more for
Yes.
starch and then this dextran.
Yes, dextran. Yes, sir. Yes.
Yeah, there is a comparison between
Oh,
contrast, dextran, starch, and this saline. And we
saline.
have used all this
Nice.
thing. And then probably for RCA, saline itself is sufficient.
It's enough. Yes, sir. Yes, sir.
But
Yes, sir.
left
Few
system,
cases I also have used.
yeah. But left system, we are
Yes.
not
Yes, sir.
sure.
Thank you, sir.
It varies from case to case.
Case to case.
Thank you, sir. Thank you for your inputs.
So I think we'll go to the next presenter, Dr. Mahadevan. He'll be talking on the current guidelines for this imaging system now. Dr. Mahadevan, it's over to you, sir.
Can you see my slide, sir?
Yeah, we can see it, Doctor.
Okay, sir. So sorry, sir. I'm actually the speaker is for this is Dr. Sundar because of his end up in emergency. I was supposed to replace him the talk. So my talk of the day is the global guidelines for the management. I thank the chairpersons as all the speakers for wonderful enlightening about the importance of imaging in coronavirus. Also, I thank my professor Dr. Kannan, who is also a part of this meeting. He's my professor. When I was doing my cardiology, I was working as assistant professor under him. So my talk of the day is the global guidelines for the management of coronary artery disease, focusing on the guidelines published by ESC and AHS for this matters. So what is the new in the last 8 months? What we infer, what we get from ESC 2024 and ACC 2025. So it's the outline, the methodology, and the class of recommendations are the main focus of this image guide assisted guidelines. So the main pattern is from the working groups, that is the task force. They have included the importance of guidance, the framing the guidelines. So when the class 1 guidelines means is recommended as indicated, though they have much more evidence and the robust to support the a procedure or a molecule that can be used or that be recommended as a class 1. Level of evidence is we are inferred from multiple RCT trials or meta-analysis which supports the usage of the procedure or molecules. And class 2B or there is some sort of inferior to the class 1, and level of B evidence is based upon a single randomized control trial or a non-randomized trials, and level C is consistent of opinion from the experts. So what we infer from the 2024 EAC guidelines, especially focusing on imaging, will be the top of the list. So these are the key takeaways. The EAC 2024 has clearly enrolled. The imaging should be performed on all the complex cases, particularly left main or bifurcations or lesions having more length as a class 1 indications. So when you are planning to do any form of PCI, especially focusing on the complex lesions, you are going for a bifurcation disease or high chunk of calcium is there or left main disease, you have to use imaging. Either you can use IVS or OCT. This is recommended by the ES guidance. It also echoed by and ACC guidance also enrolled. When you want to plan any procedure focusing on the left main or complex lesions, either you have to use IVS or OCT. What is the purpose of OCT that can be used? The purpose of using it is complex lesions means you can assess the thickness of the calciums and you can assess the morphology of the lesions, whether it is a lipid content or a fibrofatty. So you can use the tool, you can use the hardware based upon the morphology of the lesions and also predict the thrombus formations and the rupture of the plaques, which may be particularly useful when you're handling the ACS patients. And after stenting is also can assess opposition of the stent struts, any dissection is there or any gain in the maximum stented area, which all be the cumulative points what we get in futures, because the people may have at risk of stent thrombosis or target lesion failures can be predicted when you do the imaging and the index procedures. So let us focus on what are the evidence we have to support the usage of OCT in this complex subset of peoples. So these are many trials was conducted to focus on the OCT. So what are the data that supports whether it is useful or beneficial in terms of the efficacy aspect as well as the perfectness of the procedures. So we have many number of trials. iLumen trial was conducted, was compared with the OCT with angiographic guidance PCI. Another October trial was in bifurcation. This is OCT was compared with the angiographic guidance PCI in a bifurcation. This is Noctivus was compared with the OCT with this IVS. And there is meta-analysis of all the data. They are pooled all the meta-analysis data to see which arm is very good, whether you are going to use OCT or you are going to IVS or angio alone to predict the successful of the procedures. Now, Occupy is also same as that of the iLumen, that is OCT in the complex PCA with compared to the angiographic cells. So, network of all the analysis, when they pool all the data together, the what is efficacy aspect what we get, what are the safety endpoint we get when you use OCT and compared to that of angiographic alone when you define the analysis. The meta-analysis incorporate nearly 12,000 people were nearly 12,000 people were enrolled, and many of the target lesion failure, cardiac death, all-cause mortality rates on all MI, stent thrombosis, everything is very, very low. It shows the efficacious aspect in terms of your procedure. On the other hand, also shows the safety endpoint, the problem of stent thrombosis, target lesion failure, revascularizations, everything is very, very low when you use image as a guidelines for your procedures. And iLumen as one of the trial showed the superiority of the imaging, the usage of imaging guidance compared to the angiographic alone. So if you use imaging guide, especially OCT, compared to the angiographic guidance, the problem of event is very, very low. So you can reduce the complications. Major dissection can be reduced, malapposition can be reduced, tissue protrusions can be reduced. On the other hand, you can increase the MSA by 7%. So by using the tool, compared to that of angiographic alone, you can increase the MSA so that the longer lesions, later part of incident stenosis be very, very low. And also you can avoid the complications, especially dissections or malappositions during the procedure after the procedures. These all the things. So you see the illumin data, the major malposition, dissection, and the stent expansion is phenomenally very high compared to the angiogram arm, and tissue protrusions. Everything is very low in OCT arm. These are the tail marks that seeks the good quality of the procedure what we do. So successful PCA depends upon the patient should not have any malposition, patient should not have any dissection or tissue protection. On the other hand, the MSA should be a little bit more compared to the angiographic arm alone. The other point is the OCT guided PCA and compared to the angiographic alone, the incidence of stent thrombosis is very low. Not only during 1 year, even it carries more than 2 years. The data shows even if you do the procedure perfectly right, the problem of event of stent thrombosis is reduced even during long-term follow-ups. And also death or any MI related to stent thrombosis is also very low. This is the what any cardiologist wants for our patients. So we need a good results. At the same time, long-term benefit for the patient should be there. So this has been addressed by the illumin trial that clearly showed the event of stent thrombosis and death or MI due to stent thrombosis is very low when you use OCT when compared to the angiographic guided successful PCIs. And also you can use analysis. The data is what we get, the subgroup analysis. They have clearly showed you get a larger MSA and the greater stent expansions. The luminal area is very well gained and the procedural complications very low. The event of MACE and the target vascular failure, revascularizations is not that much when you use OCT when compared to the angiographic guidance. So any patients, if they are handling a complex case like bifurcations or left main, it's better to use any imaging guidelines, especially OCT, when you want to reduce the major events. On the other hand, to improve the safety or efficacy of the procedure what you do. So all-cause mortality and cardiac death are very low in the people using OCT arm than compared to the angiographic arms. So illumin trial when compared to the October trial, that October trial is another trial told about the PCI in a bifurcation disease. They clearly alluded that OCT guidance, the complex lesions, maybe a left main or maybe a calcified lesions, long lesions, or maybe a bifurcation disease, the event, the target vessel failure is drastically, significantly reduced, even if you compare with that of angiographic curves. So October trial clearly showed the primary endpoint, maybe a CV death, all-cause mortality, or cumulative events, any MACE events is reduced by 28%. When you do bifurcation disease, maybe professional or decay correction things, the OCT guidance superior showed much more superiority results in bifurcation disease and reduce MACE events by 28%. So subgroup analysis, when you do OCT on the pullback, the first pullback as well as after the standing, the final OCT. So instead of not doing, many people may not do final OCTs because of contrast, because a large volume of contrast used because of time consumes. When you do the final OCT to assess the stent expansion, to assess the dissection, to assess the tissue protrusions, so everything, the final OCT people arm showed much more benefit in terms of reduction of MACE events. So it is mandatory to do either do main vessel stenting when you do professional stenting strategies, or you have to do both main vessel and stent branch when you do all the double stent techniques, both pre and final OCT should be there. So another study that was conducted was to assess the importance of PCA guided image guided PCA is Renovate complex. They use compared to OCT with angiographic alone, OCT IVS with angiography alone, and angiographic OCT with IVS. So all the things, image guidelines showed statistical significant reductions of all events. So whether you use OCT, whether you use IVS, the incidence of events is very drastically reduced. And when you compare the two imaging modalities, whether OCT or IVS, there may be some drastic reduction in events when you use OCT, but it may not have a statistical significance. So this is the OCT clinical evidence supports for ESC. These are the trials based upon the ESC enrolled. It's a class 1 indication. Based upon these OCT trial, ESC has given a green signal that you have to use any image, especially OCT, when you handle complex lesions, when you have bifurcation disease, when you have left main disease, based upon the illumin trial, October trial, and Renovate complex PCA. These are the trials based upon large 2 or 3 large randomized trial supports the usage of these molecules. And as Octavius is they want to compare between the OCT and IVS. They want to do what happens when you use OCT arm, when you have IVS. The primary endpoint is cardiac death, target vessel MI, or target revascularization. So it's 1 year follow-up data was shown. So there is a it is a non-inferiority trial to prove the OCT is non-inferior in terms of IVS in terms of this primary event. The primary non-inferiority has been proved. the OCT is non-inferior in terms of 5 years, in terms of reduction of the primary endpoint, maybe MACE events or a cardiac death. But only one point is when you use OCT, there is a probability of a little amount of increase in contrast is there. But follow-up of the impact of the negative impact of the contrast in terms of contrast-induced nephropathy is very, very low when you use the contrast, compared to the usage of contrast volume in OCTs. And these are the Occupy trial that clearly showed the angiography or OCT for the complex lesions. The primary endpoint is phenomenally reduced in people on OCT, and the secondary endpoint, maybe a pre-procedure MI, is reduced by 64%. So Occupy is one of the trial that clearly showed the primary endpoint of cardiac death, MI, stent thrombosis, or ischemia-driven revascularization at 1 year is drastically reduced by 38%, and secondary events, target vessel revasculations are reduced by 64% at end of 1 year. So it is better to use any imaging modality instead of going based upon angiographic guidelines alone, where we miss many things like malapposition, stent dissections cannot be identified in a two-dimensional angiographic view alone. In the ACT, what we have, whether have any ACT, ACS data, so OCT, ACS, we have a tactics data. This is a registry data, what we get from Japan. The observational study, prospective multi-center observation, they have clearly showed even ACS, when you use OCT to reduce the stratified risk, the probability of you can achieve TIMI3 flow, the stent area, luminal area, you can get more compared to the angiographic evidence. So stent expansion can be good. The luminal area, acquiring luminal area is very, very good. And achievement of stent 3, and you can also morphology can be addressed. What is the major culprit behind the ACS? The erosion or an ulcer or a thrombus, or you can the morphology can be assessed. And you can size the stent, especially when you have a problem with acute coronary syndromes where sizing becomes a matter. So stent sizing or everything. So everything is that morphology, sizing of the lesion, sizing of the stent, and optimization can be addressed. These all be translated in terms of long-term safety outcomes. So Optimal is also another registry data that got from China in 8 centers in China. They all showed compared to that of angiography, OCT reduced major all-cause death and cardiac death over a period. This was presented in TCT. Now, under this Atlas trial, this is also registry, especially in people with ACS. The Atlas trial is conducted. This is also prospective. It is a single-arm, multi-center registry that was conducted. That also clearly showed the feasibility of OCT interface. In ACS, whether it is feasible to OCT, the trial has clearly alluded. Yes, the feasibility is phenomenally very, very high. Nearly 80% of the ACS can accommodate usage of OCT, and not that much. And the component of OCT can assess the morphology of lesions. Many of them we call the stent sizing, stent optimization, everything can be done even in ACS. These all translated in terms of long-term benefit of the individuals. In conclusions, over 12,000 people they had used intravascular imaging becomes that may be the reason for the gold standard use of these molecules. And by using imaging, you can reduce all target lesion failures. There are much more safety benefit in terms of reduction of stent thrombosis, reduction of MI, reduction of all-cause death. And out of imaging, the OCT improves the procedural and patient-related outcomes. You can achieve much more MSA, and many trials have clearly alluded the superiority of OCT compared to the angiographic alone. And also, you can also reduce the complications, especially dissections or malapposition or trend supposition, so many things. Even though we don't have the head-to-head comparison to say the superiority of either IVAS is superior or OCT is superior, but a few data supports that marginally little bit non-inferiority has been proven OCT compared to the IVAS. But only one thing is OCT uses contrast, but contrast-induced nephropathy is phenomenally very, very statistically non-significant when compared to the other tools. And this is a model tool of by bot, this Altrian tool. This is a AI powered. So what is the importance of AI powered? Means you can do an actionable OCTs. So you can also have a co-registrations. You can do instead of what insights we get angiography, you can also add it to that. On top of angiographic insights, we can also assess the morphology, whether the calcium is there or not. So it is very easy and simple to use. It's a software that will tell where is the EL to L, where is the amount of calcium is there, what is the thickness of the calcium. So it is easy for us to promptly take what we have to do next. So we can also stent size. We got to also assess the what modification of calcium we have to do based upon other AI tool generated reports what we have. So this becomes very, very easy for the intervention cardiologists to take the decisions on the table without any time delays. So thank you. This is the slide represented by the board. I'm presenting on behalf of the board. Thank you.
Well, thank you so much, Mahadevan sir. And then you have clearly covered the entire recent updates and guidelines. And very important part is it is imaging is class 1 indication. That is the main point. And I have seen that a lot of my friends and colleagues have hesitation in doing OCT in an acute MI. Although we have been doing it for a very long time, probably more than 10, 12 years, that right from 2017, we have been using this. And there is some apprehension, as you rightly pointed, almost around 75 to 80% of patients, you will be in a position to do OCT in acute coronary syndrome. That is ASC elevation MI. Probably some 20 to 25%, like whoever is in cardiogenic shock, pulmonary edema, or huge thrombotic lesion, or some very unstable cases, probably where you may not be in a position to do an initial OCT. So that is the limitation in ACS. Apart from that, most of the time you can do. But the advantage what we have seen is when you do it in ACS, you will get enormous information. Your treatment modality itself will change. All your decisions will change. When you look at an angio in an acute MI, most of the time you will be underestimating the size of the vessel. Number two is you will not be knowing the exact pathology of the acute MI. If it is a huge lipidic plaque, most of our guys, they put a balloon dilate, they produce slow flow. And usually avoiding slow flow is a very important point in primary angioplasty or in a PCI when you do for ACS. For that, I have felt that OCT gives extremely useful benefit, but there is a lot of limitation. Most of my people say that acute MI itself is an emergency payment agreement, night, you do it at the night or odd hours, juniors will be doing. So these are the reasons why it has not picked up in ACS. But probably if all things are all favorable, I think it is best to use an imaging during acute MI also. Apart from all these complex lesions like left main, calcified, long lesion, probably it is very, very useful. Kannan sir, what do you think about it, sir? What is your opinion about imaging and then current aspects?
Yeah, Mahadevan has covered very well. He has taken the entire gamut of how lesion is approached and how it's better to, because you know the anatomy and you know the pathology, what is happening there, and do it. And the results in all the trials have also shown favorable results. I think that will be the optimal, and I think Selvarmani must be having the maximum experience in acute coronary syndrome. I think
Yeah, we have done plenty of it, and probably we have been using it for last so many years. So it has become a routine.
Personally. Yeah, it's definitely. See, the thing is, many are hesitant, as you said, because it's midnight. Juniors are doing, and they just want to open the artery the earliest and restore the hemodynamics.
Yeah.
So it's difficult because many of them single operator centers. We have a setup like with cardiothoracic backup, and you have got colleagues to help you. It's fine.
Yeah.
Single operator centers, if it happens at midnight, the objective is to give flow to the artery. Then the rest of them becomes next. But as you say, Serotic is like in Jawad Farooq's case, where the ostium of the LAD was not very clearly visualized at all. That group of situations, definitely when you're doing an ostial circumflex, I think definitely the imaging may be an advantage.
Yeah. So it has been an excellent discussion, and Mahadevan sir highlighted the importance of our imaging today, and excellent presentation from Thiagu and Aziz and Farooq sir, and good discussion by Dr. Kannan. Also, you gave important comments, sir, and probably future, although it has gradually improved. When we started doing imaging so many years back, we did not have much of evidence, but now we have a lot of evidence to say that it is a very useful tool, and probably, as Farooq was also pointed out, it is still not spread out very well. There are so many cath labs, so many intervention cardiologists, but usage of imaging is limited. And probably in India, it is less than 7, 6, 8% of PCI. Probably there's a huge scope for this to improve so that the long-term results are better. You saw that left main bifurcation done long time back. It's one example, but similarly, we have so many patients where we have done image-guided left main 2 stent, single stent, and follow up for so many years, more than probably 10, 12, 15 years, doing very well. But only thing is, we are competing with CABG. When you are competing with CABG, if your initial results are very good, probably long-term results also should be good. So that is the implication. Otherwise, it's very difficult to compete with Lima. Lima is one thing. Forget about the venous graft. Venous grafts are inferior to stents, but Lima is still a very good option in most of the cases, which is holding CABG as a better one. But if you do a good job, I think we can at least come near Lima. That is what is my feeling. So I think for that, imaging is one of the useful tool that we should make use of it. Apart from techniques and whatever guidelines we have for the whatever techniques you decide for left main bifurcation and other bifurcation.
Salomoni, there is a question in chat box actually. How much percentage one can land osteal stents, sir? Is there any way to correctly land on the osteum? That was the question actually.
Okay, so let us see. I couldn't see that here. Rian, how much percentage at? Okay, osteal landing is always a difficult aspect, and OCT wise, there is a technique called as boom technique. That is bifurcation osteal OCT mapping technique, where if you have angio co-registration and you do an OCT and co-register, almost around 80% of the time you will land within 1 millimeter difference, and 10% of the time it will be exact at the ostium. But another 10% it can be somewhere between 70 to somewhere between probably 1 to 2 millimeter difference. So that is what the studies have said that. And as rightly said, banging exactly on the ostium is difficult even today. That is why most of the time we try to do crossover. You put from the left main into the LAD rather than trying to land in the ostium. But there are exceptional cases where you have a clear landing in the ostium, or you use OCT with boom technique where you can really fix the ostium. Or if there is a big discrepancy, left main is 5.56 and the LAD is looking small, 3.5, where you feel probably it is very difficult, so you can land in ostium. Apart from that, most of the time today we recommend crossover rather than ostial landing. And yeah, that is what he has asked the percentage. This is the percentage. Almost around 80% of the time it will be between 1 to 2 millimeter from the ostium, but 10% you can exactly land on the ostium if you use boom technique. So, any other comments?
Sir, Ramkumar this side.
Yes.
Sir, it's been like more than 10 years you've been using OCT, sir. So I really witnessed the way how actually you've been taken that OCT into the next level. So because now actually we seeing that in entire Tamil Nadu, that OCT not only they are using for MLD and Max, or actually now they are using for beyond MLD Max. Like, so you are very earlier and you adapted about how the predictors of perforation OCT will helpful, the prediction of side branch closure and prediction of slow flow. These all the things actually because after this thing actually now everybody started doing it. Not only for MLD Max, the OCT actually is really helping to predict the complication what and all this thing actually is going to happen. So
What is the status of now at present OFR over MLD Max now at present? OCT functional evaluation.
That is going to take time. It is currently we are not using it. It is not available. In future, actually we are doing one study called complete study where we use imaging and functional FFR. And for my surprise, we have enrolled around some 50 cases now. Many times FFR and OCT lumen is not correlating. So to decide on treatment even today, we have so many guidelines, but functionally and image-wise, correlation is a little bit difficult. But we have approximate guidelines like if lumen is so much, if it is less than 2.5 in OCT, probably it is going to be FFR positive. And less than 1.9 is definitely positive, but it may not hold true because FFR takes into the viability of the myocardium, area of distribution, and not only that, not only the degree of stenosis. So when you do that, there is really very difficult to take a decision. But as of today, we can make use of both. If you are using imaging, probably not only lumen area, look at other predictors of inflammation or instability like thin cap fibrotheroma, huge lipid, and then probably signs of inflammation like macrophages and ruptured plaque. In such cases, probably imaging will be helpful. Where you cannot use FFR because in ACS or in a culprit lesion, FFR is useless. It is useful only in non-culprit lesions. So for non-culprit, use physiology, and probably in culprit, you will have to take imaging, use guidance and treat the lesion. So that is the current task. That is how we are doing now.
Sir, actually, for Farooq sir, this Ultreon 3.0, actually, this will give some answers, sir. So, like,
It has
actually,
a
the
OFR.
yes, so which will be FR it is
It has a
coming.
OFR.
Yes, sir.
I'm not talking about FFR, OCT based.
Yes,
No,
sir.
that is still not available. It is still under trial. They have
Vision
still
1,
not launched in US also. They are
yeah,
going to
yes,
launch.
Vision 1, Vision 2 data is already released. Sir. It has like IFR and RFR, 80% accuracy with an FFR. They also found that 80% it has accuracy with an FFR. But anyway, with all once it is coming to in all your hands, so then actually we'll get to know about it more clarity once it will be there, sir. Yes, sir. Final comment, sir. Yes, sir.
Okay, anything, probably I think final comments from Dr. Kannan, if he's still there. Kannan, I can't see you.
Yeah, yes, sir. Yeah, I'm here. I'm here.
Yes,
So, one
sir.
is very big learning for all, actually. So, very good points, especially when you had contrast for this university. Very good points I got. And I think it's a wonderful discussion. And I think Salomoni, with all his wide experience, has given a lot of insight to the entire meeting.
Yeah, we are still learning, sir, because so many new techniques
There's
and
one more
new.
question I think he has asked in the OCT with role in spontaneous coronary dissection.
Yes. Yeah, that's a very important thing. We have a few cases where we have done OCT in SCAD. The usefulness of OCT is, there are three types of SCAD. There are type 2 and type 3 OCT is very safe, comfortable. Type 1 where dissection is extending right from the proximal, doing an OCT with high force contrast injection might create extension of this dissection. That is a problem. But if there is a doubt, if angiographically, if it is very clear that it is looking like a spontaneous coronary artery dissection, probably there is no role for OCT because it can extend. But in type 2, type 3, you cannot make out angiographically. You need OCT to diagnose spontaneous coronary artery disease. It will be mimicking just like an atherosclerotic lesion, but it will be an intramural hematoma producing that luminal stenosis, which you cannot predict without doing an IVUS. But in a type 1 thing, if you feel it is going to extend, you can do an IVUS and see that there is a spontaneous dissection. But picking up SCAD on IVUS is very difficult. But it's very easy on OCT, except for this point. Like when there is a dissection, probably when you're injecting a very high pressure injection with a contrast, it can extend the dissection rarely. That is only in type 1 SCAD. In type 2, type 3, it is very safe you can do, which you cannot diagnose without OCT.
The other point is, the OCT is one of the very useful modality to differentiate when you have the irregular filling defect angiographically, the SCAD versus recanalized thrombus actually. The recanalized thrombus definitely will pick out the classical lotus root appearance or a panda face appearance. It is peculiar for the OCT image. There is one of the point you can differentiate when you suspect a scan.
I think Cecily ma'am actually, ma'am want to say something. Cecily ma'am.
Sir, sorry, extremely sorry. I was listening to everyone's talk and the case presentations. It was excellent with Dr. Selvamani sir's inputs and Professor Kannan sir's inputs. It was a great discussion. A little bit held up today, sir, so I was not able to concentrate much. One thing regarding these. The first case, the distal edge dissection, which was present and stenting done for that patient, the first case. Actually, if the dissections are not that significant, actually, the Copenhagen study of OCT with OCT, they told if there is angiographically, there is no dissection, but OCT, we are able to pick up the dissection. And of course, the angulation more than 60° with the 3 millimeter length and all those things. But angiographically, if there is no dissection at all, OCT alone, we are able to pick up small dissections. We need not even do anything for such patients. And the follow-up, almost 90%, there is no MACE events in the follow-up. So sometimes angiographically, we are not able to detect dissections, but when we do the OCT, we pick it up, and sometimes we chase for it and go ahead with this. But for Sir's case, I think the angulation was more than 60 degrees, and it was more than 3 millimeter, no, sir? So that's why
Yeah.
you
Yeah,
the-
Yeah, madam,
moreover,
it was
stenting.
more
It
of
was very
6
more than
mm
appropriate.
length,
Yeah.
so we put it and
yeah,
Yes,
more
sir.
than
Yes, sir.
more than that, it was a geographical miss. Actually,
Yes.
they have not done an pre-OCT.
pre-OCT. Yeah.
So the length of stent was lesser. Actually, there was
Yes.
significant stenosis beyond that stent also. So lucky that he had a dissection, they put one more stent and treated.
And
So probably the outflow disease also was treated, which is good for the patient.
yes, sir.
And
And also, while crossing and recrossing the LCX, I think OCT, where the recross was exactly through which strut, I think those images, was it put? I don't know whether I missed it or not.
No,
But
actually that was not put, and that I didn't take also, because I did only the last step as well. After everything was done, OCT was taken because patient was quite unstable after OM1 DEB, and he was 8 years old, and I was not contemplating for that.
But yes, sir. Otherwise, usually it matters a lot because of the stent.
Yeah, we did show that 3D bifurcation mode, that there were no stent struts across the LCX
great, sir.
osteum. That was good. Opening was there.
Yes, it was a great. Otherwise, it
Yes,
was a
thank you.
great case. And
Yes.
Dr. Selvamani says rightly said. Always, I think if it is needed, we have to always send for CABG. But of course, we can do with the optimal results. But L6 osteum, I think recently ESC president also had told that however perfectly we do with OCT IVS, the risk of reocclusion from 6 months to 1 year is almost 50%. It was really, I was quite astonished with these words that L6 osteum is definitely, however perfectly we do, there is always a risk of reocclusion, restenosis. But we do not know, we still have DEB, the role of DEB in such cases. We do not know how much it will be. And sir, Professor Dr. Selvamani, I just one doubt. What will be your ideas? Have we put in a depth for such cases, L6 osteum, a depth, and then if necessary a stent, or a stent and then a depth if for the L6 osteum, whether the outcomes may improve? You have any idea or any case reports on that?
See here, what the point you said is, when there is a real complex disease like osteal circumflex disease, in the index procedure, if you are unable to produce that adequate lumen extension, then the restenosis rate there is around 40%. So if you produce an adequate lumen dilatation at the osteal circumflex, then it is not so high. Number one. This is for two-stent strategy. But for a single stent strategy, the reincidence, that is the occurrence of restenosis, is less than 10% there in the circumflex. So in that also, if there are two options, if you are doing a final kissing balloon for the circumflex with a single stent technique, if you use a drug-eluting balloon, Again, restenosis rate is lesser compared to plain balloon dilatation. So given an option for kissing for the circumflex and the left main, finally what you can do is you can put a drug-eluting balloon in the circ and kiss and come out. That is better than using a normal balloon. That is the current scenario that we have. So it all depends like what you are planning, and many times you may not do a final kiss at all. It is not recommended. And we still don't have the exact guidelines when to kiss, when not to kiss in a single stent strategy in the circumflex. So, but probably what I do is when I do an OCT, if I see significant connectors and struts across the side branch, I go and kiss it. Otherwise, if there are no struts, many times when you do an adequate pot, you may not see any struts across the connectors across the side branch. Then there is no need for any kissing at all. So that is based on imaging. Without imaging, how to decide whether to kiss or not is really difficult. Angiographical appearance may not be good. And if at all, if you are kissing, if all finances, everything is available, better use a drug-eluting balloon and kiss. That is better than ordinary balloon. That is the current scenario, but we'll have to wait and see for all the results.
And for hostile landing of LAD, though it is a very tough job and it is very difficult, as you rightly mentioned, sir, that we need to overlap with the angiographic and OCT images. But one thing is, if there is a large ramus, if there is a large ramus, and if we feel that it could get compromised, I think that is one occasion wherein we trying to land with just the ostial LAD, at least one or two struts into the left main, because a large ramus, recently I had a young female who had a large ramus with the ostial LAD 100% cut off with the anterior wall MI. She was very young, just 32 years. I have those images probably. If possible next case we can post, but we didn't have the that she was a young female, no OCT I was for that at that time for us, for the patient, so we had to take her up immediately. It was a large ramus also, L6, so I didn't want to compromise, but without any didn't have OCT I was, but just stented just a few stent struts from the LAD, and luckily, patient survives, sir. She'll be under follow-up. But your view on that, sir, when there is a large ramus, the trifurcation, but we need to land in the ostium, or you will go ahead once again and keep it in the left main and do the stenting, sir? What is your, especially in such a primary case? Yeah.
Yeah, in a chronic stable angina or it's a non-ACS case, the scenario is totally different. You can do anything, but probably you can do a crossover, that is the best. But in an acute coronary syndrome, whatever you do, it is not in their hands because thrombus can get squeezed into any branch. And then probably outcome is probably we'll have to do it and then see. But high probability, whatever mortality or whatever difficulty we have is usually in acute coronary syndrome because they'll have huge lipid burden or only thrombotic lesion, where when you are handling that thrombus, probably what happens is this gets squeezed into the bifurcation and non-culprit or vessel also becomes culprit now. When the LAD is only occluded, you bring the thrombus back into left main, it goes to ramus or circumflex, even that also gets infarcted, patient becomes sick. So we have treated such patients for so many years and we have seen all these problems. But today what I do is, if there is anything like this, if the patient is affordable, we do lacing there. Lace the thrombus out, just put them on heparin for 1 or 2 days, stabilize, just establish flow, and probably after 3 or 4 days, bring them back, do imaging, and then stent. That is very, very safe. But in a left main thrombotic lesion, that to young people, usually it is going to be thrombus. When you remove the thrombus, if there is no laser, you can use thrombosection. Do thrombosection and then bring them back after 3 or 4 days, do imaging, and then take a decision. That is a more safe way of doing it. And because we are treating, when you're putting a stent across the left main, you are touching the non-culprit vessel also. So that is not ideal in a primary. A patient can, that too, if it is a dominant circ, we are really taking a big chance. So today, after seeing all this experience for so many years now, for such cases, this is what I'm doing now with good results.
Yes, sir, sure, sir. But that's what in the government sector, we don't have this laser and all those things. So, yes, sir, we take care, because the patient is also in shock and we need to do something. We take them up, but I will also project the data. As you rightly said, sir, if laser is available, or any gadgets are there to remove the thrombus.
Thrombosection or something.
We
Yeah,
find
we
and
know we do
meticulous,
have a lot of cases like that. I do like just thrombosection, keep them on GP2B3A, and 2 to 3 days. Once pain settles, we can bring them back. In that case, they are having good outcome. Depends on the thrombus burden.
burden. Yes, sir.
Burden.
But maybe next time I will show some of the cases, almost many with young MI with 100% occlusion. Patient is in shock and we need to recover them. Just we put all these drugs in the sideline as well as intracoronary, and meticulously we do it and come out somehow by God's grace, I think, without much gadgets in
Actually,
hand.
in TAPPUS and total trial, where the thrombus burden was routine thrombosection was deferred, but in our scenario, that what we see is more of thrombotic in acute coronary syndrome, but
Yes,
that
sir.
to young individuals, and in that case, definitely this thrombosection helps, and GP2B3 or other whatever the
Yes, definitely.
thrombotic like pharmacological measures we give, and after 48 hours, we might see that nothing is there. Even like after you can see the clear vessels as well. Nowadays, that can be added with the help of imaging, as sir was giving
Yes,
inputs like
imaging
that.
definitely will be helpful in such situations, whether we need to
Situations.
stent or need not stent, to just leave them and
Yes.
come.
Yeah.
It's
See,
like
if something is in the mid LAD or in the mid RCA, whatever you do, it may not have immediate outcomes.
impact.
But
Yes,
in
sir.
the left main, you really are not sure, because the moment you stent, you get slow flow in all the three vessels, the patient goes down. So
Yes, sir.
it's not guaranteed. Outcome is not guaranteed. So
Yes.
that is why we do this technique now with all those previous experiences. This
We
is
can just
looking to
do
be
the
safer.
lacing and then
Establish
put it-
flow, just calm down the thrombus for 2-3 days, and then stent, nothing happens.
Yes, sir. That's a great takeaway message from you, sir. Definitely. But when there is laser is not available, your option would be, sir?
Thrombosection, madam. Before laser, we were
Yes, sir.
doing
Thrombosection we do.
Yeah, yeah.
We have thrombosection catheters. We have, that is not an issue. But that's what we established the flow somehow. The thing is, it's not always we need to send them. That's I take up that message, but we establish the flow. But if necessary, we put in a stent, but not to post dilate very severely or anything. Just establish the flow and come out. And we're able. I will show some of the many cases. The data I will show, sir, definitely.
Yeah, sure, madam.
But
sure.
as you rightly said, yes, sir. In a center, in a government center, whatever maximum thrombosection we have, sir. Thrombosection, but laser we don't have. And for imaging, we have only for elective cases we are able to do the imaging, like with Ram Kumar
No,
bringing
madam,
in
you
all
are
the
doing
gadgets.
an excellent job at the government setting. So whatever you are doing is a great service to the society, madam.
No,
Sir is here, ma'am is here. I think so. The laser is
especially.
going to be there in all the hospitals. I think it's okay.
So yeah, especially nowadays, even in Madurai government hospital, they are doing excellent job. And Chennai, you people are doing great, and we are really proud of you, madam. Doing it all the service for the people,
Yes, sir.
especially in the government setup. It's a really great service.
Thanks, hello.
Thank you, sir. But we should do whatever is optimal and best
Yeah,
for the
best for
patient.
the best for the patient.
That is, we have to achieve excellence. I think there is no compromise in government or private. We have to achieve the optimal and excellent results, and it should be scientifically also correct, as you rightly said.
Correct,
We
madam.
can't, since we don't have, we should not compromise on anything. So that is our goal also. So we try to achieve maximum outcomes, sir. But as you said, we will also ask for laser and all the other, so that we cannot compromise on such things.
Yes.
Thank you so much, sir. Thank you.
Thank you, madam. Thank you.
Thank you, sir. Thank you.
So I think you can conclude. Vignesh or Ramkumar, whoever is.
Sir, actually, this is the part 7, sir, in ACC, CCS guidelines, the class 1 evidence for after OCT. And almost actually in this all 7 program, including today, I think 700 plus actually attendees so far attended, sir. And this we're not going to stop here. Again, actually, this will be continue for coming months also. And it's been quite very great support from you, sir, for all the program. And especially, I really thank you, ma'am, Sisi ma'am, and Kannan, sir, and Tyagarajan, sir, Farooq, sir, Aziz, sir, and Sujay, sir, actually, silent, sir. So actually, thank you so much, each and everyone actually contributed, and it's excellent. Actually, this is one of the best discussed session in all 7 program. What I feel, sir. Thanks a lot. Thank you so much for all your supports and contribution, and this will definitely will help us and motivate and encourage us getting that imaging penetration to more patients. Thanks a lot. Thank you so much. And from my team, actually Vignesh and Satish actually put a lot of effort for this all this season. So I'm really thankful to my team also. Thank you so much. Thank you so much.
Thank you.
Thank you,
Thank
sir.
you,
Thank you,
sir.
everybody.
Thank you. Bye-bye.
And good night.
Good night, sir.
Good night.